Today we'll be looking at NCLEX questions on ECG analysis and interpretation. I'm going to advise, just because of time, you pause the video just to read the questions. I'm just going to be jumping into the questions so that the answer, so that we don't waste so much time on running through the question. Okay, so again, I'll advise you pause the video and then you can unpause it to listen to the answer. So again, let's look at what would our answer be here? Assume you must have paused the video and read through the question. So the key word I want you to take note of here is they tell us that the PR intervals are between 0.16 seconds. So again, what is your normal PR interval? What should your normal PR interval be? Remember, the PR interval starts from here. Okay, so if I can grab a hope. Okay, so the PR interval starts from here and ends here. And it represents the time it takes for cardiac impulse to spread from the atrials to the ventricles. And it shouldn't be more than 5 small boxes. So this is 1 small box, 2 small box, 3 small box, 4 small box, 5 small box. It shouldn't be more than 5 small boxes. If it's more than 5 small boxes, we say it is prolonged. So now they're asking us, what do we interpret this interval to be? So this is a normal finding. So number 1 will be our correct answer. Okay, you can pause the video, read the question, and then unpause. So I'm going to assume you've done that. Again, what was it? Look at the stem of the question. Potassium level, 6.3. With the next gen NCLEX styled questions, you'll be given what the normal value should be. So you can do a quick interpretation of your lab values. You don't have to memorize all of it. But again, 6.3, that tells me the potassium level is elevated. So my question is about hyperkalemia, and I need to understand the associated ECG findings. So if I have a potassium level of more than 5.0, I know my patient is hyperkalemic. And what are we going to see on our ECG? We're going to see a tall peaked T wave. So number 2 is going to be our correct answer. So number 2, it's tall peaked T wave. That's what you're going to see when your potassium level is elevated. Usually a U wave, a depressed ST segment, that happens the other way around. So you're going to see T wave inversion, ST segment depression. So that's our ST segment that's depressed. You're going to see a prominent U wave. So that's what happens with hypokalemia. But with hyperkalemia, you're going to see the P wave peaked. So that's what we mean by peaked. So you see a prominent, a peaked T wave. You also see the P wave flattens. So normally where we should have a P wave is missing. You will see the PR interval will be prolonged, more than, just like we said at the last slide, it will be more than 5 small boxes, and the QRS complex will be wide. So that tells me my patient is hyperkalemic. So number 2 would be our correct answer. Okay, so assume you've paused the video and you've read the question. So they're asking us what this rhythm is. Again, you need to interpret this rhythm. First of all, what is the rate? I like starting with the rate. Does it look fast? Does it look slow? Again, you can always use the 1,500 rule to determine the rate, where we said you want to count the number of small boxes. So if I count the number of small boxes between my arrow waves, so these are your arrow waves, so these are my arrow waves. So I want to count the number of small boxes between our arrow waves. So I know this is 5 small boxes here. In this big box, there's another 5, that's 10. There's another 5, that's 15. So 16, 17, 18, let's say 18 or 19 small boxes. And then we want to divide that by 1,500. So let's say 18 small boxes. You want to divide that by 1,500. And that's going to give us 83 points, something. So again, what's the normal heart rate? It should be between 60 and 100. So if we have 83 here, it tells me the heart rate is within range. It's normal. Again, look at the rhythm. Look at the RR intervals. So we said this was our arrow wave, this was our arrow wave, this was our arrow wave. Look at the interval between them. Are they evenly spaced out? Are they matching out? If it is, then we say the rhythm is regular. So that's how you want to determine regularity. Look at the RR intervals. Again, do we have a P wave? Yes, we do. And for every P wave, is there a corresponding QRS complex? Yes, We see a P wave, we see an arrow wave. We see a P wave, we see an arrow wave. We see another P wave, and there's an arrow wave. That tells me that's a normal finding. And you also want to look at our QRS complex. The width of the QRS complex, it shouldn't be more than 3 small boxes. It shouldn't be more than 3 small boxes. If it is within 3 small boxes, we say it is narrow. So again, all of the QRS complexes on this rhythm strip look to be within 3 small boxes. And those are normal findings that you will see in a normal sinus rhythm. So number 4 is our correct answer. Now the keyword again there is asystole, no pulse. And they're asking us what the graduate nurse will do that will need to intervene. If the patient is an asystole, doesn't have a pulse, then we do not shock asystole. So you want to remember that asystole, your flat line, that's a non-shockable rhythm. The other non-shockable rhythm would be what? A pulseless electrical activities. So you want to remember this for the NCLEX. There are 2 rhythms you don't want to shock. Your flat line, which is asystole, and pulseless electrical activity. Again, on the other side, if we need to shock, we want to shock our ventricular fibrillation, and we also want to shock our pulseless ventricular tachycardias. So these are the only 2 rhythms that we shock, and we do not shock asystole or pulseless electrical activities. So again, number 4 would be my correct answer if the graduate nurse attempts to defibrillate asystole. Again, assume you've unpaused the video. Now, first of all, before we dive in, we want to try to identify what this rhythm is. When I look at this rhythm, I see that there's no definitive P wave, but you can see all these waves. These are what we call fibrillatory waves. They're kind of fibrillating. They're kind of fibrillating there. So those are called your fibrillatory waves. So we notice that there are no definitive P waves. We see fibrillatory waves before QRS complexes, and the QRS complexes are kind of narrow. So that tells me that it's just one impulse that goes into the ventricle to give us our QRS complex. Again, look at the RR intervals. It's kind of long here. It's a bit shorter. This is very short. And again, it widens here. So it tells me that my RR interval, this rhythm is an irregular rhythm. This is what we call atrial fibrillation. That's the atrial is fibrillatory. That's why we're getting these fibrillatory waves. And again, with atrial fibrillation, there's this common complication, or a very severe complication that is associated with atrial fibrillation, which is the development of a thrombus. So, you know, as the atrials are fibrillating, the blood tends to stagnate. And because of that loss of organized atrial muscle contraction and that atrial kick, the blood pools in the atria and then begins to clot. And it increases the risk of that clot moving into the pulmonary system or into the cerebral vessels, which could result to maybe pulmonary emboli or a cerebral emboli. And that's why the patient is usually placed on this long-term anticoagulant medication. So number 4 is going to be my correct answer, because the atrials are quivering, blood flows sluggishly through them, and clots can form and all of that. Okay, which rhythm is this? Again, I can see the interval. See how close together the RR waves are. That tells me this heart rate is fast. Again, you can also use our 1,500 divided by the number of small boxes to get what the exact heart rate is. But again, just by face value, looking at it, I know this heart rate is fast. So this is a tachycardic rhythm. Again, I look at the RR interval. It looks normal. It looks normal. It looks regular, rather. So the RR interval looks regular. So this is a regular rhythm, it's a tachycardic rhythm. And again, look at the QRS complexes. Remember we said our QRS complex should not be more than 3 small boxes. Again, these ones look like they are less than 3 small boxes. And that tells me the QRS complexes are narrow. Remember, if the QRS complex is narrow, we know that the impulse that is giving us or is generating that QRS complex is coming from above. It's coming from above the ventricles. So that's why you will hear terms like supraventricular. Supra means above. Ventricular means so above the ventricles. Again, we said this reading was fast. So this would be a supraventricular tachycardia. Again, remember, in clients with supraventricular tachycardia, with a regular rhythm, narrow QRS complexes, the initial treatment would be to carry out vagal maneuvers. For example, asking the patient to bear down, asking them to maybe put in a cold compress in the for pediatric population, or maybe, any vagal maneuver you can. So number one would be our correct answer. That act of bearing down is going to, as if they're having a bowel movement, is going to help to increase intrathoracic pressure and to also stimulate the vagus nerve. Remember, the vagus nerve supplies the parasympathetic nerve fibers to the heart. So once it's stimulated, it's going to result in a slowed electrical conduction through the AV node. So number one is going to be our correct answer. Okay, again, I can look at this, and on face value, I know that this rhythm is fast. So this is a tachycardic rhythm. I can see how close together they are. So that tells me the heart rate is fast. But look at the QRS complexes. They look wide. The QRS complexes look wide. Remember, we said if the impulse that is generating the rhythm is causing the QRS complex to be narrow, we know it's coming from above the ventricle. But if the QRS complex is wide, then we know it's coming from within the ventricle. Again, we already said it's a heart rate that's fast, which is a tachycardic rate. So this would be a ventricular tachycardia. And more or less, most times in an NCLEX questions, there are some questions that are not real questions. This rhythm is just here to throw you off, because if I use my decision tree, I know I'm going to eliminate option 3 and 4 because they are implementation options. And I know I need to assess this patient first, because clients in ventricular tachycardias could be pulseless, or they could even have a pulse. So that's the determining factor. My client is in ventricular tachycardia, yes, but does he have a pulse? Because that's going to determine how you're going to manage this patient. Okay, so again, number one is going to be my correct answer. I need to determine if this is a pulseless ventricular tachycardia, or this patient has a ventricular tachycardia and has a pulse. So number one is going to be my correct answer. So remember, ventricular tachycardias with a pulse, if we assess this patient and he has a pulse, we need to further assess for clinical stability or instability. You need to look out for signs of instability like hypotension, altered mental status, signs of shock, chest pain, acute heart failure. Because you want to remember that the unstable client, if the client is unstable and he has a VT with a pulse, usually we treat them with synchronized cardioversion. So you want to remember that synchronized cardioversion for unstable tachycardias with a pulse, very vital for the NCLEX. Synchronized cardioversion for unstable tachycardias with a pulse. Whereas a client who is stable in ventricular tachycardia with a pulse, usually we treat them with antiarrhythmic medications like your amiodarone, your procainamide, your sotalol, and all of that. Okay, so number one would be our correct answer. Okay, so I'm going to pause this. So now they're asking us which action should the nurse take first upon reaching the bedside with a client with ventricular tachycardia. Again, you want to assess. Remember your nursing template. Your first step in the nursing process is to carry out an assessment. So again, I'm going to eliminate option 1 and 3, even without reading this question, because I know I need to assess my patient first before doing any other thing. So again, if the client has a ventricular tachycardia, I want to assess his level of consciousness. I want to assess if he has a pulse and all of that. Okay. Now the client is in VT, is in ventricular tachycardia, and is pulseless. What do we want to do? The ICD has fired twice. Remember your BLS. Once we shock, what's the next thing we do? We want to initiate chest compression. Don't do any other thing. Don't carry any assessment. Don't check for a pulse, all of that. Once you shock the patient, go back to chest compression. So option 3 would be our correct answer. Okay, once I see this, it just reminds me of M. I can write an M over this. What is actually what we call Torsades, the point, the twisting of the point is a kind of ventricular tachycardia. But the ones we saw previously were kind of having the same shape. So those ones, we call them monomorphic ventricular tachycardia. Mono means one, morphic means shape. But again, you can see this one is a ventricular tachycardia with multiple shapes. So this will be called a polymorphic ventricular tachycardia, or Torsades de points. So you're going to see the QRS complexes that keep changing in shape and in size in a characteristic twisting pattern. And it's usually due to, most times it's due to a prolonged QT interval, mostly as a result of electrolyte imbalance. Which electrolyte? Your magnesium. So again, it's usually caused as a result of hypomagnesemia. That's one of the most common causes. So for this client, we need to give magnesium. So option 3 would be our correct answer. So again, once you see this kind of wave that's twisting on itself, you just want to remember hypomagnesemia, and we need to give magnesium. Okay, how about this? Again, there are some questions. This is a very long question, but if I just go down to the assessment, I know that this would be a circulatory option, this would be a breathing option, this would be a circulatory option, this would not be related to A, B, or C. So again, you can take your time, read the question, but I know number 2 is going to be the answer, because most times it's not about knowing all of the content, it's knowing the techniques to solve some of these answers. So even without reading this question, I know that option 2 is the correct answer. Okay, so how about this? Assume you've read the question, no measurable heart rate, no P wave, no QRS complex. This client is in a possible cardiac arrest. What do we need to do? We need to defibrillate. Okay, assume you've paused the question or you've paused the video, out of hospital cardiac arrest, and the client does not follow command and remains comatose. Out of hospital cardiac arrest, does not follow command, remains comatose. We need to initiate what we call targeted temperature management. So option 2 would be our correct option. Remember, neurologic injury is the most common cause of mortality in clients who have had cardiac arrest. So inducing this targeted temperature management, it used to be called therapeutic hypothermia. You know, you want to keep the client within a temperature range of 32 to 36 for at least 24 hours. You need to know those numbers, between 32 and 36 degrees for at least 24 hours, because this has been shown to decrease mortality rates, and it has also been shown to improve neurologic outcome. So again, remember, if you've resuscitated your patient, he's out of the cardiac arrest in the post-resuscitation phase. If he's unresponsive, this is not following command, if he remains comatose, you need to initiate targeted temperature management. We need to put him between 32 to 36 degrees for 24 hours before we rewarm him. How about this? Again, I'm going to go with my assessment option, because I know I want to assess. Remember the first step of the nursing process. So even if I don't know what this rhythm is, even though I know this is a second degree AV block, a type 1 second degree AV block, where I know I need to assess for evidence of symptoms associated with this kind of rhythm, maybe if it's hypotensive, if it's dizzy, if it's having shortness of breath. Remember, treatment would be indicated if your patient has symptoms. So again, I need to assess the patient first. I need to look out for those symptoms that are associated with this rhythm. So number 2 is going to be my correct answer. Again, it's not about knowing all of the content. It's not about knowing how to apply the techniques and the skills that we teach on our courses. Okay. Assume you've paused the question and you've read through. Again, what do we note? We see that the P waves are not associated with the QRS complexes. That's a possible block there. That tells me there's a possible block. But again, what do we get from the introductory statement? We know that he has undergone a radio frequency catheter ablation. Remember, this procedure is performed through a transvenous cardiac catheterization, where they try to ablate. What do you mean ablate? Or they try to burn electrical pathways that are causing maybe tachycardias in that patient. So they try to burn off those electrical pathways to stop those tachycardias. And this ablation, if it's carried out near the AV node, it can damage conduction, causing various degrees of AV block. So that's possibly what might be happening in this patient. So again, we can see that the P waves are not associated with our QRS complex. The P waves are not associated with our QRS complex. What do we need to do? We need to notify the cardiologist, and we need to prepare for temporary pacing. So again, remember, no pulse, he's not breathing, he's unresponsive, and all of that, we need to defibrillate. Again, if the patient is unstable with tachycardia, we need to carry out synchronized cardioversion. Again, if the patient has a heart block, we'll need to carry out pacing. Again, our first line management would be to give atropine, but again, the electrical management would be to carry out pacing. So for this patient, we need to notify the cardiologist and prepare for pacing. So how about this? Again, we're already talking about pacing, and they're asking us which rhythm should the nurse document. Again, look out for what we call our pacer spikes. So these are what we call our pacer spikes. Where do you see them? For me, I see this in front of our QRS complex. We see this coming in front of our QRS complex. So again, I'll call this a ventricular paced rhythm. So this would be a ventricular paced rhythm because that's where I'm seeing my pacer spikes. If it was in front of my P waves, then that would be atrial pacing. So number 3 would be a correct answer. Assume you've unpaused the video, and this is a who do you see first? Which client should we see first? Again, you need to prioritize. Those are the steps, those are the techniques we're going to teach you on our course. And again, I know that option 2 would be my correct answer. Look at this keyword here, demand pacemaker. Remember, with demand pacemaker, the rate is already set. So it is going to be set at 70, and it will override the heart or the pacemaker of the heart if the rate goes below 70. But here, what do we see? We are still seeing bradycardia. We are still seeing bradycardia, which is a heart rate of less than 60 in a patient with a demand pacemaker. So that tells me there's possible failure to capture, or the pacemaker is sending the impulse, but the myocardium does not depolarize, or there's no pacers. Something is happening with number 2, and that would be my priority patient. So I need to see this patient. Number 2 would be our correct answer. How about this? Again, look at the rhythm. We are seeing our pacer spikes, and we're not seeing any corresponding activity in the myocardium. So this would be a failure to capture. So it's causing this patient to be bradycardic, it's causing this patient to be hypotensive, and the priority would be to carry out transcutaneous pacing, because transcutaneous pacing is going to help to normalize the heart rate, it's going to stabilize the blood pressure, and it will help to adequately perfuse organs until probably a permanent pacemaker is either replaced or repaired. So option 3 would be our correct answer. And with option 4, which is not a real question, because I know my priority would always be to assess. So option 4 would be my correct answer.